Welcome to part 3 of 3 presentations on the cervical spine. It's a continuation of part 2. So again, we're going to continue to look at a range of fractures and injuries of the cervical spine and finish up with a checklist to make sure that you know how to assess the images.
So the flexion teardrop fracture, this is a highly unstable injury caused by severe flexion and axial loading. So if we think back to our 3 columns of Dennis, there is disruption to the anterior column and there is disruption to the posterior column. So this is a highly unstable injury. So if the neck goes forward into flexion, the posterior column has been disrupted, so it's unstable in flexion. If the patient goes into extension, then there has been disruption to the anterior column, so it's unstable in extension. Okay, so let's have a close look at this picture. So A is adequate. Okay, we've got the base of the skull on. 1, 2, 3, 4, 5, 6, 7. So in clinical practice, you would need to be able to see the whole of T1. But this is fine for this in this context. Okay, S is for soft tissue. So we come down our prevertebral soft tissue line. So it should be 7 millimeters or 30% of the vertebral body width at C2. And it should be 22 millimeters at 7 or 100% of the vertebral body width. If you can see, there is bulging, marked bulging to the prevertebral stripe. So there is soft tissue swelling. We can see quite clearly that's causing the hemorrhage there. So we have an abnormal soft tissue line. Okay, A is for alignment. So we come down the anterior vertebral line and suddenly we've got a step here. There's a step in the anterior vertebral line at C7. This is abnormal. So let's look at our posterior vertebral line. And it's a little bit angulated here, but there is no disruption to the posterior line. Let's have a look at our spinolaminar line. That's probably in alignment, so that's okay. Let's look at our interspinous distance. There is marked diastasis of the interspinous distance between C6 and C7. This is abnormal. There is disruption to the ligaments. The remaining interspinous distances are normal. So we have disruption to the anterior longitudinal line and we have disruption to the interspinous distance. Okay, B is for bones. Nothing going on there, nothing going on in the mandible. There's our anterior tubercle of C1. Let's look at C2, go around the cortex of C3, C4, C5, C6. And here we have a wedge compression of C7 with loss of the anterior vertebral height. We've got a little step in the cortex there, marked depression to the superior vertebral inflate. We have a compression fracture of C7. Let's look at the posterior ligament, the posterior aspects. So we'll go up the articular pillars, checking the pedicles. Look at the posterior arch C1, look at your lamina. Look at your spinous processes, and we can see now we've got an avulsion to the C6 spinous process. So we have ligamentous disruption with an avulsion of the spinous process of C6. Okay, so C is joints. Let's look at these intervertebral disc spaces. So we've got loss of the intervertebral disc space between C6 and C7. Got normal disc space there. Let's have a quick look at our facets. Facets are all normal. Okay. Let's look at this again. So our flexion teardrop fracture. We've got disruption to the anterior line. We've got disruption through to the interspinous distance. We've got a fracture to C7 and to the spinous process of C6. So we have disruption to the anterior column and the posterior column. So this is an unstable injury. So what is it? It's a fracture. Where? C7 vertebral body and C6 spinous process. How? Compression with loss of the anterior vertebral body height and distraction. Now we have the less significant extension teardrop fracture, and it's caused by forced extension. So remember, your anterior longitudinal ligament runs along the anterior margin of the vertebral bodies. So as it goes into forced extension, the anterior longitudinal ligament avulses the antero-inferior corner of the vertebral body. Okay, it tends to occur at C2 and C3. Because only the anterior cortex has been disrupted, the posterior column has all been preserved. It means that when this head goes into flexion, because the posterior column hasn't been disrupted, these ligaments are able to hold the head when it goes forward into flexion. However, if the patient goes into extension, because there has been disruption to the anterior longitudinal ligament, if the head goes back into extension, it is unstable because there is disruption to the anterior longitudinal ligament. Okay, so let's assess this image. A is for adequate. Yep, we got the base of skull on here, okay. 1, 2, 3, 4, 5, 6, 7. You would want to be able to see T1 in clinical practice, but otherwise we accept this. Okay, S is for soft tissue. So let's come down our pre-vertebral line. It should be 7 millimeters at 2, or the equivalent of 1/3 of the vertebral body width. And at 7, it should be 22 at 7, the equivalent of 100% of the vertebral body width. There's a bit of, I think, a bit of soft tissue swelling in front of C2, but if you actually look at C3, there's no soft tissue swelling. So this indicates that the pre-vertebral soft tissue line is not a sensitive line. So a normal pre-vertebral soft tissue line does not exclude an injury. Okay, so A is for adequate, S is for soft tissue, A is alignment. So we come down the clivus, points to the posterior cortex of C2. So we go down our anterior vertebral line, and we can see that there is a disruption to the cortex there, But if you actually go in alignment, the vertebral body of C2, it still remains in alignment with the vertebral body of C3. Sorry, the vertebral body of C3 remains in alignment with the vertebral body of C4. Vertebral body C5, 6 and 7 are all in alignment. So your anterior vertebral line is actually in alignment. So we'll go down our up our posterior vertebral body line. That's normal. Let's look at our spinolaminar line. Normal. There's an apparent widening of the interspinous space posteriorly, but that's just normal. That's just the large spinous process of C7, the vertebra prominens, and T1. So we look at the other interspinous distances. These are normal, so the interspinous distance is fine. So our alignment of the anterior, posterior and the spinolaminar line is all normal. So let's do bones. Okay. So we've got quite prominent mastoid air cells, but there's nothing going on in the skull. Nothing wrong with the mandible. Hyoid looks good. Anterior tubercle. Let's go around the odontal process and C2. Let's go around C3. Yep, we've got disruption of the cortex. We have a fracture through the anterior inferior corner of the vertebral body of C3. C4 looks good. Let's go around the pedicles. Let's look at the posterior arch of C1. Let's look at the articular pillars. Let's look at the lamina. Let's look at the spinous processes. Okay, great. So now we've done A is for adequate, S is for soft tissue, B is for A is for alignment, B is for bones, C is for cartilage. Okay, let's look at these intervertebral disc spaces. They're looking okay. A little bit of narrowing here, but there are some early spondylotic changes. So this is most likely due to spondylotic changes caused by disc degeneration, not trauma. Normal, normal. Let's look at our facet joints. Some real narrowing of the facet joints posteriorly here. We can see marked sclerosis. This is facet joint arthropathy. This is not due to degenerative changes. This is due to facet joint arthropathy. Degenerative change to the facets. Okay. So only one column has been affected. We've got a little fracture. It's a avulsion fracture to the anterior inferior corner of the vertebral body. Okay. So what is it? It's a fracture. Where? Anterior inferior cortex of C3. How? Minimally displaced. So remember, on our AP, we want to check our spinous processes to see if they're all in alignment. And if we have rotation of the spinous processes away from the midline, that indicates that there is a disruption to the facets. And the side that the spinous processes rotate to is the side that there's the injury. And we have widening of the interspinous distance, which we can clearly see on this lateral view. Remember, if the head is held in flexion, it creates an abnormal interspinous distance, but we can see that the cervical spine in this particular lateral view is not being held in marked flexion, so this is definitely abnormal. Let's look at this more closely. So let's look at this more closely. The facets, the articular pillars and the facet joints, they should sit on one on top of each other. They should be a nice diamond shape. Here we've got a double diamond. This is the bow tie sign. This is the double diamond. This indicates that there is rotation to the facet joints. Now, be careful. If you don't have a lateral cervical spine. If your patient is rotated, you will get the facets will not be superimposed. So you will get a false impression of a unilateral facet joint dislocation if your patient is rotated. But if we look carefully, the inferior aspects of the articular pillars and facets are pretty much superimposed. We only see the outline of the vertebrae with the vertebrae is completely superimposed, got a nice square vertebrae. We don't have a rotated effect to it. So this indicates that this patient is actually lateral. So we have, because we have one facet joint remains contiguous with the inferior facet joint, so we've only got unilateral facet joint dislocation. So we get the double diamonds or the bow tie sign. We've got widening of the interspinous distance. On a unilateral facet joint dislocation, the vertebra only moves anterior to the vertebra below by no more than 25% of the vertebral body. So it only slips forward by no more than 25% of the vertebral body. Okay. So what is it? It's a dislocation where C4 onto C5. How? Unilateral facet joint. Unilateral facet joint dislocations tend to involve either C4 onto C5 or C5 onto C6. These are the most common locations for it. Perched facets refer to the subluxation of both facets of the superior vertebral body in relation to the vertebral body below. So with a unilateral facet joint dislocation, one facet joint dislocates, and with perched facets, both facet joints subluxate anteriorly so that they come to sit immediately on top of the facets below, hence being called perched facets. They sit perched. So it's not a dislocation of both facet joints, which results in jumped facets. It's just a perching. So let's assess this image. Well, we haven't quite got the whole of the base of the skull on. 1, 2, 3, 4, 5, 6, 7 T1. So we've got inferiorly, we have the whole of T1 on, so that's excellent. Ideally, we would want to have more of the base of the skull. As you can see, part of the anterior tubercle of C1 has been clipped off. Okay, let's assess for the soft tissue signs. So let's come down the prevertebral soft tissue line. So it's 7 at 2 and 22 at 7, and we can see that anterior to C5, C6, there's bulging, so there is a degree of soft tissue swelling there anteriorly. So we have an abnormal soft tissue sign. So let's assess for alignment. So we come down the anterior cortex of the odontopeg and C2, C3, C4. Now there's a supposed apparent spondylolisthesis, very slight spondylolisthesis of C4 onto C5. But if you look posteriorly, the facets aren't quite superimposed, so there's a degree of rotation. So this is actually normal. Come down to C5, C6, we can see that C5 has moved anterior in relation to C6, very slight, but there is a slight spondylolisthesis of C5 onto C6, so this is abnormal. Keep coming down, that's rest normal. Now let's do the posterior vertebral line. So we come down the posterior cortex and we get to see how C4, C5 posterior cortex is normal. Get to C5, C6 and we can quite clearly see that there's a step where C5 moves anteriorly in relation to C6. So we have disruption of the posterior vertebral line and then we keep coming down posteriorly. Now we look at our spinal laminar line and we get to C5, 6 and we can see that there is now disruption of the spinolaminar line of C5, C6. Let's look at the interspinous distance. So we've got virtually no interspinous distance, but as we can see we've got rotation here. And so therefore this is normal, should not be misconstrued as abnormal. So remember with that apparent spondylolisthesis, this is a very normal interspinous distance. This is the facet joints are rotated, so this is just projection. But now we get to C5, 6 and we can quite clearly see there is marked diastasis of the interspinous distance. So we have a normal C4, C5 interspinous distance, we have a normal C6, C7 interspinous distance, so this is abnormal. So with regards to alignment, we have an abnormal anterior vertebral line, we have an abnormal posterior vertebral line, we have an abnormal spinolaminar line, and an abnormal interspinous distance. Okay, B for bones. Let's have a quick check of the cortices. Go around the cortex of all of them. Have a quick little look along the facets, the articular pillars. Check your pedicles. Go down the lamina. Go down around the spinous processes. So bones are good. Cartilage, let's look at the intervertebral disc space, all looking very good. So there's a slight loss of joint space anteriorly of C5, C6, which isn't surprising as the facets have perched, but actually the intervertebral disc space are pretty well preserved. Look at our facets. So these joints aren't actually too bad, although there's a rotation, we can see that there's an abnormal facet joint relationship at C5, C6, but the remaining facets are looking okay. Alright, so let's carry on to the next slide to learn how to describe for what, where, how. So what is it? It's subluxation. Where? C5 on C6. How? Perched facets. So now we have jumped facets. This is a dislocation. This is where the facet joints of the superior vertebra move forward in front of the facets of the vertebra below. This is a really bad injury. If you can imagine your spinal column, your spinal cord runs along this region around here, and now suddenly the facets of the superior vertebra have moved anterior to those facets below, so there is complete occlusion of the spinal cord. This will be associated with significant neurological defect. So A is adequate. Yeah, we got the base of the skull. 1, 2, 3, 4, 5, 6, 7. So we can't see T1. So clinical practice, we would want to do swimmer's view. S, soft tissue. Okay, let's come down our pre-cervical soft tissue line, and we've got bulging here of the prevertebral soft tissue line. So it should be 7 at 2 or 30% of the vertebral body, and at 7 it should be 22 millimeters or 100% of the vertebral body. So we have marked soft tissue swelling here, indicating that there is a underlying abnormality. So we've got A for adequate, we've got S for soft tissue. Now we've got alignment. So we come down our anterior vertebral line. Whoa, look at that, there is a big old step there. We have an abnormal anterior longitudinal line. Let's come down our posterior longitudinal line. Oh, that's disrupted, and the posterior longitudinal line is disrupted. There, this is abnormal. Let's look at our spinolaminar line. Down we go, down, down, down. Oh, and there is a step, and we can see there is disruption to our spinolaminar line. Look at our interspinous distance. It doesn't really help with this patient because they've got a grossly degenerative spine, but we can actually see there is a bit of interspinous disc space diastasis. Okay, so we've done alignment. Let's do B for bones. Yep, nothing going on in the skull vault. Anterior tubercle. Okay, C2 vertebral body. C3 vertebral body, C4, C5. Let's look at our facets, articular pillars I should say. Anterior arch of the tubercle, anterior arch of the, the posterior arch of C1. Go down the lamina. Yeah, that's fine. Look at our spinous processes. Normal. Okay, so we have no further fractures. C is for cartilage. Let's look at intervertebral disc space. It's squishy, but if you look here, we can see spondylotic changes. We've got moderate spondylotic changes. We've got reduction in intervertebral disc space. We've got anterior osteophytes. We have increased sclerosis of the vertebral end plate. So this is degenerative. This is normal. This squish of the intervertebral disc space is abnormal. This is not normal. So we have compression to the intervertebral disc space. Okay, let's have a look at our facets. Well, our facets are, so you've got the abnormal facet joint here. So this is abnormal. The remaining facets are really narrowed and sclerotic, and this is really severe facet joint arthropathy. So that's a degenerative appearance to a spine. Okay, let's move on. So what is it? It's dislocation. Where? C6 onto C7. How? Jumped facets. So spinous process fractures, isolated fractures of the spinous processes are usually, they're pretty insignificant. They're very stable injury, are referred to as a clay shoveler's fracture. It's caused by sudden flexion force on the neck and back muscles. They tend to be oblique and they tend to be distracted, and they may be multiple. So remember, if you find a fracture, keep on looking for another one. Okay, A is adequate. Yep, we got the base of the skull on. C1, 2, 3, 4, 5, 6. Can't really see 7, so clinically this is inadequate, but otherwise we'll accept it. Okay, S is for soft tissues. Let's come down the prevertebral soft tissue line. So it should be 7 at 2 and 22 at 7. This is normal. Let's look at the anterior line. So we come down our anterior vertebral bodies. Now be aware, you can see this really big prominent osteophyte. This is normal. Don't follow the osteophyte down, you just draw the alignment of the anterior vertebral body. This is actually okay, this is all right. Go down the up the posterior vertebral line, that's normal. Let's look at our spinolaminar line. So we've got a lucent line in our spinal lamella there, but actually this is normal. Let's look at the interspinous distances. They're not too bad actually. Okay, so B is bone, yeah, that's fine. Anterior tubercle, odontoid peg, and vertebral body C2, C3, C4, C5, C6. Let's look at the articular pillars. Let's look at the posterior arch of C1, the lamina. And we can now see a little fracture there through the spinous process of C6. We look again, we've got another lucent line, so we've got distracted fracture through the spinous process of C5. Got another fracture, big with small distraction through C4. We've got another fracture through C5. So we've got distracted fractures to the spinous processes of C3, 4, 5, 6. C2 looks okay. Okay. So what is it? It's a fracture where C3, C4, C5, C6 spinous processes, how slightly distracted. Okay, so to recap, the cervical spine checklist. On the peg view, do you have alignment of the lateral masses? Is there a fracture through the base of the peg? On your AP view, look at the alignment of the spinous processes. Is the distance between them equal? Lateral view, is C1 visible? Is T1 visible? Do you have pre-cervical soft tissue swelling? Is the anterior tubercle of C1 closely aligned to the anterior border of C2? Is the Harris ring intact? Are the anterior, posterior and spinal lamellar lines normal? Do you have interspinous widening? Check every cortex so you don't miss a fracture.